3 millimeter Straumann implant. And then on the left side, again, you can see severely deficient ridges, right? So if I go back, so the goal here, she wanted to do autogenous block grafts here to increase the ridge volume, but then she felt that the vestibular depth was pretty shallow, high frenal attachments. I think the keratinized mucosa is relatively okay, but to improve her outcomes, she went ahead and did a nice, predictable, simple free gingival graft, and secured it really well. Stability is really key for these grafts to take. And then this is 4 weeks post-op. And then she went ahead and finished her block grafts bilaterally here. So you can appreciate, just by doing a simple, it doesn't take away too much time, right? This procedure probably delays the GBR or ridge augmentation procedures by maybe about 6 weeks. But look at the quality of tissues that you can get. And then when you place your implants, you have a very good protection of the implants. You have a deeper vestibule, the denture on the top or the prosthesis, really the patient is able to keep it clean. And it also helps with the restorative procedure. So simple things like augmenting the gingival grafting prior to implants really goes a long way. Okay, there's a benefit of converting the phenotype to a thicker. It facilitates with ridge augmentation, because remember, when you're doing a ridge augmentation, you really need thick soft tissue when you're overcorrecting the ridges, right? And then it also helps in maintaining peri-implant health. So simple things. So let's talk about a little bit about soft tissue grafting. We're still in the topic of keratinized tissue. So we talked about a little bit about free gingival grafts and their applications on teeth and implants and prior to implants. What about alternatives? Sometimes some of our patients may not have patient selection, maybe their medical history or their palates are pretty shallow, or they do not want us to take tissues from their own palates because of a previous bad experience, I would say. So there are some artificial matrices. I know Dr. Gautami told me that in India, you do a lot of mucograft. So right now, at least in the US, in addition to FGG or CTG that we use for augmenting keratinized tissue, so we also have done some mucografts. Again, mucografts is a collagen-derived matrix. I think it's an animal-derived product. It's a spongy structure, helps with clot stabilization and cell ingrowth. And then you could use it as you can expose it for your patients if your goal is to create keratinized tissue, or you could cover the flap over it and do root coverage outcomes. So there are some studies out there. This is a nice paper from Mariano Sanz. So they actually compared this mucograft or the collagen matrix derivative with connective tissue graft to increase the keratinized tissue, and they actually found pretty similar results, at least in the short term. But the patients really loved it because there was no palate to cut open and things like that. But again, for the palate morbidity, we know that from studies by Selipsky and Bob that mucogingival surgeries are actually the most painful to our patients, then osseous surgeries, flap surgeries, or implant therapy. So the simple things is when you do any palatal surgeries to give your patient some stent, or a co-pack, and then they usually, they'll really thank you because, one unhappy patient may not come back or he may not refer more patients if you cut open their palate. So again, so the advantage of mucografts is, again, there is no so there is no donor site morbidity. There is less pain compared with autogenous grafts, and there is reduced surgical chair side time, right? Of course, these matrices are a little bit more expensive when you talk about cost benefits for your patients and for your own practice financials. The color matching is much better than in free gingival grafts, and then they claim at least early revascularization and better wound healing. So here I'm going to just quickly show another article here by the Schmitz group. And what they found was they did a vestibuloplasty here. That was a study on teeth. This was a vestibuloplasty paper. So here they compared doing a vestibuloplasty with the porcine collagen matrix, which is, of course, pigs. That's where the mucograft is taken from, versus the FGG. And they found that both the FGG and the collagen matrix are both suitable for the regeneration of peri-implant keratinized mucosa with a sufficiently long-term stability. So with the collagen matrix, the harvesting procedures are basically invalid. There's no harvesting time. Surgery time is reduced and the regenerated tissues can have more aesthetic appearance. But again, we need to have really longer-term studies to really evaluate if this is stable over time or you lose that keratinization. But I think one key is, actually, I'm going to tell you when we do the patient. So this is one of the cases that they demonstrate here, where they covered this implant case, the vestibule. They created a partial denudation flap here and put a mucograft here, and it heals pretty well overall. So this is one of my cases, and Dr. Jimmy Nelson, he graduated 2 years ago. He's now practicing in Houston area. So this is one of his patients who complained again of some sensitivity and soreness during brushing. But as you can see here, this is definitely not an RT1, and we told the patient we cannot do complete root coverage, but we can definitely try to widen the zone of his keratinization tissue. And the patient did not have maybe a shallow palate, or he did not want to open up his palate. So he presents with at least a minimum amount of kg, some recessions. So Dr. Nelson here decided to do a mucograft. So he also took a CT scan. So typically, it's not standard of care. I'm going to talk to you about the CT scan benefits when I talk about this full arch soft tissue cases. But I think because he was trying to do a full mouth mucograft here, we took a CBCT just to see how much bone the patient had in terms of facial distances and fenestrations, and identified the mental foramen, because that's very important. Remember the original Bowers paper that talks about minimal amount of keratinized mucosa around, especially the lower premolars, 1.8. And if you're doing a free gingival graft, you really have to be careful to isolate your nerve and identify how far it is. So you can have a panoramic or an OPG, as we call it in India, or you can have a CBCT just to identify where your nerve is. So my philosophy is you do split thickness at the coronal aspect, and as you go below to the mental foramen, you make it more full thickness flap and kind of use a wet gauze or certain specific instruments to move the nerve away while you're placing your graft. So anyways, this is just to show you surgical planning, where the foramen is and how the bone looks facially, because that's important as well, especially if you're doing root coverage and you have no bone, your outcomes are not going to be excellent. So he did this full arch mucograft. He did posteriorly, and then bilaterally and also anteriorly. So the key with mucograft is the protocol. The manufacturer recommends that you leave some amount of keratinized tissue, because remember, this mucograft is from animal origin. It's the source, again, it's not human. So the genetic component may be lacking here. So where does sorry, my bad. Okay. So the epithelial cells actually migrate from the surrounding keratinized tissues over the mucograft, and then it basically acts as a scaffold, and then it finally keratinizes over. So he placed this mucograft exactly like how you do a free gingival graft, and he secured it. And then we also placed a co-pack. He used a 7-0 polypropylene microsutures here. And this is how it healed in a month. Now, again, we don't really have long-term here, but you can see from 2 millimeters, we almost doubled or even maybe tripled the amount of keratinized tissue, though we were not able to cover the roots, but the patient was satisfied and was able to go back to brushing. And then since we modified the phenotype here, the risk of future progression is reduced. The frenum relocations were also done in this case. So I just thought I'll show you one case of mucograft which worked, at least in our hands. So moving away, any questions so far? Anyone has any questions to me? Dr. Gautami, please let me know if I'm going too slow, or do we have time left? I can speed it up.
So we can take up the questions, I think at the end of the presentation.
Okay, perfect. Thank you, Dr. Vikender. Sounds like a plan. So let's move on to the gingival recessions. Should we treat gingival recessions? So we talked about keratinized tissue. Evidence is conflicting depending on whose articles we read. But again, we know that in patients who have adequate keratinized tissue, even with recessions, if they have good oral hygiene, good compliance, it is slow, right? That's what the earlier evidence showed us. But typically, clinical decisions, what do we look for? We look at patient concerns. Is the patient concerned about the aesthetics, root sensitivity, soreness while brushing? We also are worried about the tissue phenotype? Is there risk of progression of the recession? What will happen if I don't do anything here? Does the patient have a high caries risk? If I don't cover the roots, will he have more root caries, because we know cementum is more organic tissues, less inorganic than an ML. Of course, you also have restorative options. You can do bonding, you can apply fluorides, you can apply glass ionomer or MTF and so on and so forth. Or is the patient going to go into orthodontic therapy? So these are some of the factors that we may have to consider in our clinical decision making. Okay, so this is one of the recent meta-analysis studies done by Dr. Shambroni from South America and Dr. Tatakis from the Ohio State University. So they just did a long-term outcomes of untreated buccal gingival recession. So they took about 1,647 defects in good oral hygiene, and then the the study should have been done for at least 24 months. And what they found was that in this study was that at least 78.1% of the defects had increased gingival recession. So this is again based on the composite of all the previous articles done. So this shows us that even with good oral hygiene, there might be a risk of progression. But how much risk are we even talking about? Probably it's very minimal, right? So again, you have to individualize or customize the treatment of how your patients present. But the evidence currently shows that there might be a risk of further recession even in patients with good oral hygiene. So with that, I mean, again, what are some of the classic techniques that we all learn training? At least when I was a resident, 20 years ago in GDC and, in Boston University. So we used to do the Langer and Langer technique, which is the classic coronally advanced flap with connective tissue, two horizontal incisions, two vertical incisions around the CEJ. You coronally advance the flap, secure the connective tissue graft around the CEJs, and then you pull the coronal flap over it, so you get pretty good outcomes. And then you have the Group and Warren lateral sliding flap, where you move. Of course, you need to have, this is a pedicle graft, so it has its own blood supply. The key is your adjacent donor site should have adequate kg. So you just do a split thickness there, cut back incision over there, and then move your slide over to the site with recession. Depending on the thickness of the phenotype, you could decide to put a connective tissue or just do a lateral sliding flap alone. And then we have the original coronally advanced flap by itself by Harvey. So, again, this all pretty much worked very well when you had those Miller's class 1, class 2. Sometimes the clinician might decide if the tissue is thin, maybe we'll put an underlying connective tissue graft or not. And then, the people, at least the old timers like me, we're familiar with the Bernie Mollin technique, where he would do a free gingival graft first, thicken the tissue, and then he would coronally advance that thickened tissue with a coronally advanced flap to cover the root coverage. And then we are also familiar with the Tarnos semilunar technique that he uses for the maxillary anteriors, using a small semilunar incision when the teeth have adequate keratinized tissue, and then he just lets it fall over the CEJ, and and then it heals with root coverage. And then of course we had McGuire, who pioneered the principles of using a membrane and some biologics like a GTR concept for root coverage. But I don't think we are doing that as much now. Maybe you could argue that if you use a mucograft, it's kind of like a GTR. Some of the newer techniques that at least I have seen witness during my time in the residency in the US were the Pat Allen technique, the tunnel technique. So the tunnel differs that, there are no envelope incisions here, no vertical incisions here. All Dr. Allen suggests is using these specific instruments to make tunnels, and the papilla is intact here. So you're making like a big tunnel, and then you dissect through the mucogingival grafts and coronally advance the flap. So some of the advantages of the tunnel he proposes are vascularity. You're keeping the blood supply intact. So some of the PGs who are here would know the classic papers by Wilderman and others that showed that the blood supply for the gingival tissues goes epicocoronally, right? So if you're raising a flap, you're taking it off from the periosteum, PDL, you may have some vascular embarrassment. So apologies here. So with this technique, the key is to keep vascularity, and then he typically puts acellular dermal matrix to cover some of his roots. And then he uses a sling sutures, a continuous sling or interrupted slings to get his root coverage outcomes. And then one of the more popular techniques that some of the residents do in our programs are the Zucchelli coronally advanced flap, where this is of course a multiple tooth coronally advanced flap procedures, where he basically, if you're doing a quadrant of root coverage, there's a centralized tooth that you mark, and then you make these oblique incisions. These oblique incisions, the lengths are dependent on the depth of your incisions. So you create a surgical papilla, which is this one, and then you create an anatomic papilla. You deepithelize all this. So the goal is here, when you're advancing this flap, your new surgical papilla actually moves mesially and takes position of this. Because the criticism of the previous coronally advanced flap was that you have some sort of clefting in your papillary areas. So, and then Zucchelli recommends to use a connective tissue graft here. And then one of the most recent popular techniques that, at least in our program, our residents do a lot, is the Homazade from University of Southern California, the vestibular incision subperiosteal tunnel access, or also called as VISTA, where you are doing some vertical incisions in the midline, or if you're doing a full arch surgical techniques, you make multiple vertical incisions, and then you kind of dissect epico-coronally. You're going from the apex, from the mucogenital junction coronally, and then you're advancing the flaps coronally, and then you can either do connective tissue, or you could do alloderm there, or a fibroguide like a allograftic material to achieve root coverage. So I'll show you some of the techniques later on. So let's look at some literature. Since we're talking about root coverage, so is it predictable at all? So this is again a nice classic paper published in 2012 in the Journal of Clinical Periodontology by Cairo and the Pini-Prato group. So they showed here that on a single maxillary gingival recession with loss of interdental attachment, so you could say these are more like your RT2s. So these are more severe types, because we know that RT1s, it works. So what they found in this study was that they compared these recession defects, which are RT2, that means they had lost some interproximal attachment level, coronally advanced flap with connective tissue grafts. And what they found was that coronally advanced flap with connective tissue graft resulted in a more predictable complete root coverage in majority of the cases, even when there was interdental attachment loss. And these results were stable at 3 years in a subsequent publication that they published in 2015. So that tells you that if your patient has maybe a thicker phenotype presentation, RT1, maybe a coronally advanced flap by itself should be sufficient. But if they have a thinner phenotype or even some interdental attachment loss, maybe putting in a connective tissue graft inside might be more beneficial for your patient. So this is, again, a nice paper for review. So what about patient-related outcomes? We always talk about what we want to do, right? As PGs or clinicians, we might like a technique that we impose upon our patients, but I think it's also important to review what do the patients want. So this is again another paper from the same group, Cairo and Tavelli and Tonetti. So they did a systematic review of randomized control trials looking at different designs of flap designs and graft materials for root coverage. And they included patient-centered outcomes, including aesthetics, patient satisfaction, and self-reported morbidity, post-operative pain and discomfort. So, if you tell a patient, do you want to take tissue from your palate or use something else? Obviously the patient will tell you, I don't want to open up my palate, right? So here, they did pretty nice mapping here. So you can see in this figure A, so they compared, so the key is here, the graft, and then you have the technique, right? So here they compared connective tissue graft and coronally advanced flap, then they had tunneling with connective tissue graft, they had tunneling, and then they had growth factors, and then they had coronally advanced flap alone. Okay, and on the right side here, so they looked at also enamel matrix derivatives. They looked at acellular dermal matrix and PRF, which is platelet-rich fibrin, and then the xenographic collagen matrix, which is our mucograft. So what they showed was that in this study, that coronally advanced flap with connective tissue or tunnel with connective tissue graft showed superior final recession scores than coronally advanced flap alone. Now remember, these are multiple teeth. The earlier study we talked about single teeth, right? So this they compared both single and multiple, and then the growth factors, enamel matrix derivatives, and xenogenic collagen matrix. They found that they had more higher patient satisfaction, whereas with coronally advanced flap alone, they had better soft tissue texture and color matching, if you will, compared to the other techniques. So the practical implications were that actually overall, most of the patients did tolerate the root coverage procedures pretty well, and they liked actually all the procedures. The patients scored actually CTG grafts, even though they were painful, with the highest aesthetic scores, even though they had increased morbidity. So this shows us that regardless of the technique, I think coronary, if your goal is root coverage, I think connective tissue graft might give you more predictability in single or multiple recession defects. So this is another study by the Cairo group and Shambroni. And then they looked at long-term stability of gingival margin and periodontal soft tissue phenotype achieved after mucogingival therapy. So this is again systematic review. And then what they found was that the greater the baseline or keratinized tissue width of course, sorry, not baseline, at post-operative 6 to 12 months, the more stable the gingival margin is, so which is likely related to the amount of keratinized tissue and attachment that we have gained. So they also found that the use of autogenous soft tissue grafts was associated with lower recession depth increases over time. So to maximize, they concluded that to marginal gingival stability over time, so periodontal soft tissue phenotype modification means making the tissue more thicker when the baseline thickness was much less, should be strongly considered if your goal is to have more post-surgical stability. So again, you can see the overarching theme in these studies is that connective tissue graft is probably more predictable, in terms of stability and also better root coverage outcomes. So also, I mean, let's look at what about biologics? I know in many parts of the world, platelet-rich fibrin, growth factors are really a key. But what is the efficacy of biologics? So recently, I think AAP set up a working committee here. They put the group of Dr. Barucci from Michigan, and then Dr. Ortiz, who was at Iowa, and Dr. Shambroni from Columbia. So they looked at the efficacy of biologics in root coverage and gingival augmentation therapy. And then what they showed here was that the adjunctive use of autologous blood products, or example platelet-rich factors and enamel matrix derivative, did not provide substantial additional improvements in terms of clinical outcomes and patient-reported outcome measures to those achieved using coronally advanced flap alone, especially when the baseline keratinized tissue width was greater than 2 millimeters. Both the groups of PRF plus CAF and EMD plus CAF were inferior when you looked at the overall mean root coverage percentage or complete root coverage percentage and residual defect reduction and keratinized tissue width gain compared with connective tissue graft and coronary advanced flap. And then they concluded that based on this study, that connective tissue, coronary advanced flap with subepithelial connective tissue graft is still the gold standard when you're considering a root coverage therapy. But of course, not all patients might benefit, so again, do your patients really need 100% coverage? Maybe 90% is okay. Some patients may not agree to connective tissue graft, so you have to use alternative in those cases, right? So this is the decisions as clinicians we have to make. But this is what the evidence tells us we have. So let's look at some root coverage cases. I'm going to show you some full arch root coverage cases that we have done. So when we look at a case of recession, patient comes to you. So what are we looking at? We're looking at, of course, the classifying it, diagnosing it, talking about treatment options, but we also have to look at the etiological factors, right? So the patient might be faulty toothbrushing. If we go ahead and graft these patients without correcting their brushing techniques or what caused the recession in the first place, I think you're not going to help the patient, the situation, right? Initially, short term, you may have good results, but long term, those might disappear. We also have to look at history of orthodontics. Maybe the patient had history of orthodontics, so there's probably not much in terms of facial bone. The roots are too far out. Maybe you have to do some sort of corrective orthodontics to move the teeth inside your alveolar housing. Maybe the patient has thin phenotype, like how we looked at the classification system. So maybe you want to consider thickening the tissue to prevent more recessions, if that's your goal. What about history of periodontitis? We have to treat periodontitis, right? So we have to make sure that our patients are free of inflammation. They're stable, they're in maintenance program. And then we know that patients with history of periodontitis, we may not be able to achieve 100% root coverage. So maybe we have to look at some alternative options if they have recessions, like restorations or, chemical desensitizers and things like that, or maybe even tissue phenotype modification techniques. And then our tooth size arch discrepancy, that basically means that, maybe the teeth are bigger because the arch is more constricted. So, what are you going to do in these patients? Are we going to expand the arches, do some modification, do some kind of decortication, and do some grafting in those patients to kind of change the patient biotype? But clinically, what are we going to look at in these patients? You're going to, of course, look at the interproximal attachment levels, tissue phenotype. Again, it keeps coming back. Root prominence. I think what the emerging research is showing us that it depends on how prominent your roots are. And this is where a CBCT might be helpful. Again, I'm not saying that all patients will need a CT scan, but I think what at least some of the researchers in our department are showing is that if the patient's roots are very prominent, there is lack of facial bone, your root coverage procedures might be compromised. So you may want to reduce the root prominence either intraoperatively by reducing the root eminence, but again, you're risking maybe pulpal exposure, or you do some preemptive orthodontics there to lingualize and bodily move those roots. Maybe in some patients, you can restore those non-cervical carious lesions that we talked about during our Pinot Preto classifications. And then, as I mentioned again, maybe consider some adjunctive orthodontic therapy in these patients to maximize our root coverage outcomes. So with that background, so let's look at some cases that we have done in our program. So this is a full arch root coverage I'm going to show you with connective tissue graft. This is Dr. Bhakta, our senior resident. So in this case, she decided to do a full arch lower mandibular root coverage. This patient had, I believe, RT1, very minimal amount of keratinized tissue, healthy periodontally. Patient was complaining of sensitivity, soreness during brushing. So in this case, she decided to do a Vista technique, which is the vestibular incision tunnel access approach. So she showed here, we have just outlined where the actual CEJ was, and this is where she made her incisions using this technique that I talked to you about. We do some vertical incisions, which traverse to the keratinized tissue and go into the mucogingival tissue, and then the Vista kit comes with this A, B, and C. So the A instruments, you basically, once you do your incision with your 15C, now depends on how far your root coverage goes back. You may want to drop maybe some more verticals here. Then you use your instrument A to get inside and then free up all this soft tissue. Then you go with your B, this zone, the attached gingiva, you're releasing it. It's almost like a full thickness flap, you're doing it. And then you use C here to kind of not cutting out the papillae, but just trying to free up these attachments here, but keeping this interproximal attachment intact. And then you kind of try to coronally advance the flap. So this is how she did. She did some incisions here, two vestibular vertical incisions. And then she's using this instrument A and B here to kind of create this subperiosteal tunnels. And then once she has created that, she went ahead and took this connective tissue graft. We took a large connective tissue, and then using the butterfly technique, and then she switched the palette, of course. And then you see, if you go back here, we're planning to do all premolar to premolar, but this graft is not sufficient. So what we do, you kind of split it in the middle. So we call it the butterfly technique. So you expand this graft, and then you tuck it through this vertical incisions, and then you coronally advance the flap. So typically we want this gingival margin to be at least 1 or 2 millimeters beyond your CEJ based on studies by Prato, who suggested that corally advancing this flap beyond overcorrecting in terms, overcompensating, is actually beneficial to the post-surgical margin. So even before, I think, so she pre-sutures this flap before she sutures the graft. Here she etches this enamel with phosphoric acid, and then using this polypropylene sutures, these are like simple sutures, the anchoring sutures that pull the graft coronally, and then the connective tissue graft is inserted inside your tunnel, and then they are secured. So this is post-op 1 week, and then this is how the patient presents at 3 weeks. This is at 8 weeks, and this is at 12 weeks. So you can appreciate this patient, we were able to achieve almost 100% root coverage, maybe some residual recession beginning to happen here. Again, because this is the connective tissue root coverage procedure, probably the vestibule, we have shrunk it a little bit, but the results seem pretty stable. The patient was overall pretty happy in this case. So another case that one of our third years here worked on, this is a maxillary arch. Patient again has RT1 kind of defects. You can already notice here some of the contributing factors I talked to you about. Patient has a thick phenotype, again, some orthodontic malocclusion here, but the patient here refused. All adult patients sometimes, academically, theoretically, we can always say that, oh, send him to orthodontist, but how many of our patients really realistically do orthodontics, right? So in this case, so she decided to do a Vista technique here by doing some vertical incisions here and 2 vertical incisions posteriorly. So once she created those tunnels and advanced the flaps coronally, but you see these are still connected, so it helps with the blood supply. So she used the acellular dermal matrix allograft matrix material here instead of some connective tissue graft. So then she lays the graft inside, and then she uses this anchoring sutures and then secures them. And then these are the holding sutures that we are overcorrecting the gingival margins here. And then we put composite here so they're secure. So this is how the patient healed at 12 weeks. So pretty, I think, reasonable outcome here. We almost have full coverage outcomes, but again, we have to follow these patients long-term to see how they heal, how is the gingival marginal stability, because we know from earlier studies that connective tissue graft is the gold standard in terms of phenotype modification and long-term stability. But again, you see the color matching is pretty good here, so the patient was pretty happy. So switching gears, I think this is my last section. So let's talk a little bit about soft tissue deficiencies around implants. So again, these are just some pictures I caught from internet. So if we don't plan properly, we are doing too many implants. I feel today where the teeth could have been saved, and we can avoid all these complications. But again, I think that's a topic for another day, I guess. So sometimes, in addition to hard tissue complications, implant failures, so some of our patients will also experience these soft tissue complications, right? I think some of us do have this, especially in the maxillary anterior. I think maxillary anteriors is the holy grail for implant dentistry in terms. I feel it's one of the most challenging areas to place implants and restore and have ideal patient satisfaction. So, again, if we are not careful, these are the kind of results that can happen, right? So I think, in my opinion, at least, the best way to correct soft tissue deficiencies prior is always before you place the implants. Do as much augmentation as possible to avoid those situations. So this is one of our residents. He's now practicing in California, Bay Area, Dr. Hui Fan. So this is his patient. He extracted those front incisors. We call it 9 and 10. I think I'll get back. I think it's 2.1 and 2.2 according to the FDA system. And then he felt the patient was ready to place implants. But you can clearly see some soft tissue deficiency over here, right? So then, so this was our goal. So we felt that this patient was deficient, but see how we ended up with. So after the healing, this is how the soft tissue augmentation. So what happened during this surgery? So we opened the flap. we drilled the case. So you can already see here, the bone is pretty deficient in this patient. And we already know that the soft tissue was also pretty much lacking in this patient. And I think some of the important things to also consider is the patient's smile line, in addition to the phenotype thickness, and the amount of bone volume present. And we all know the Tarnow's paper, the classic papers, right? The inter-implant distance should be at least 3 millimeters. The inter-implant and the tooth distance should be at least 1.5. And the distance between the crest of the bone and the contact point for the implant restoration should be 5. If it goes more than 5, then you're in trouble. You lose the papillae. So we know all those basic concepts. I'm really not going to go into that. So this is what we did here. So we placed those 2 implants, and we recognized that the buccal bone was deficient here. So he went ahead and did some simultaneous grafting. So this is one of our pericardium membranes and some allograftic bone, and this is what we achieved. So I think this situation is much better to restore the implants than what you had in the beginning. So we did change the phenotype here completely, not with the soft tissue graft, but by adding bone and membrane. So I wanted to share this case with you. So in another case, this is a patient of mine. I saw her in private practice, a young lady from Austin. We extracted one of the tooth because it was non-restorable, huge carious lesion on the palatal aspect. I just extracted the tooth, did some socket preservation, did not really think much. And the patient comes back, this is how the tissue looked. I was happy, and I went ahead, placed an implant. I think that's reasonably good placement, right? As periodontists, I think we all will be pretty happy. But what's the problem? I mean, it's still deficient, right? The patient has high smile line. The soft tissue wall is just not there. So this is the problem. So this is my CBCT. So what do you see? This is after the extraction and the bone grafting I did in the socket. Look at this. I barely have enough bone, no buccal bone. I did not enucleate the nasopalatine duct here. If I had known that, I could have grafted this and achieved what Dr. Pham in the earlier case had achieved. I would have had much better soft tissue outcomes. So how did we address? So again, the problem is it's always better to prevent these complications than having to address them later when the patient is ready to get restored. So again, this was, again, a long time ago. This is almost 10 years old case. So now I learned my lesson. So what we did was I brought her back. I did the bone grafting along with the implant placement. Again, I put a custom healing abutment here. I also put a connective tissue graft facially here. And I let it heal for a few weeks. And then my prosthodontist put provisional restoration on this. I know it does not look excellent at this point. And then she worked on sculpting the tissue to achieve some reasonable success. Now imagine if I hadn't done that, this patient would have completely lost these papillae. Okay. And then this is how we finally restored. So thankfully for me, this patient did not have a high smile line, and we were able to achieve reasonably good outcomes, but I'm still not happy that we lost this papillae over here. So I think if you look at critically, again, I would have managed this completely differently. I would have probably done more grafting before the implant placement, and maybe an additional soft tissue grafting prior to restoration. That could have at least helped with the outcomes. So here we managed this case by soft tissue grafting at the time of second stage. We displaced the tissue buccally to augment the volume. We used a customizable healing abutment to allow the tissue to fill in coronally. And we used a provisional crown to create soft tissue contours. Okay. So now, what is the evidence for soft tissue outcomes in implant aesthetics? So this is again from one of the consensus groups papers by Dr. Zheng and Thoma, and you all may recognize some of these names here. So they again found that for implant soft tissue issues, there is always a tendency of superior aesthetic outcomes in presence of a thicker mucosa. Okay, so remember phenotype. We always need to have thicker tissue. You can achieve that by either bone grafting, a GPR kind of a technique, or a soft tissue technique. And connective tissue, according to the consensus, remains the standard in terms of increasing mucosa thickness. Now remember, we don't have as much evidence for implant-related outcomes as we had with the teeth, right? It's still a work in progress. So implants we try to throw something and see what sticks, right? But at least based on the limited evidence we have, seems like connective tissue is always the good option around implants. So this is actually one of our department publications that came out of our group. So we did a study, I think in our clinic, this was from Osteology Foundation. Dr. Lee was the PI. I had a minor role in this paper. So we looked at clinical efficacy of soft tissue augmentation on tissue preservation during immediate implant sites. This is a randomized control trial. So what we did was we placed immediate implants, and we had three groups. So one group, we did not do anything. We just placed the implant. In another group, we put connective tissue graft. And in a third group, we put the acellular dermal matrix. So what did we find? So we found that doing the soft tissue augmentation at immediate implant sites can be beneficial in maintaining soft tissue contours. Okay. However, doing this augmentation at the time of the immediate implant placement did not significantly improve the stability of peri-implant mucosal level and interproximal bone level. Okay. So we all know from the classic Buser papers that, long-term immediate implants, even though they are good at maintaining soft tissue levels, they do lose bone. So again, we feel that in this study, the soft tissue was there. It did keep the contours intact, but because we know the underlying bone remodels, so you will compensate for that. So there will be some marginal instability, even with doing soft tissue grafts. And this was not significantly different with our control group. So this was a small, short-term trial. So we still need more long-term data for these kind of studies. So this is a very good paper that we routinely use. I'm sure you all are familiar with this Zucchelli and the Tavelli group, decision-making for dental implants. So how do you manage? So, right until now, I've been telling you, do the augmentation prior to implant. So what if some of your older patients come now and you have an issue? You already have restored the implant, and then there's a soft tissue issue. So this is the nice classification that Zucchelli gives you, that at least our PG residents follow. So class 1 to class 4, and then there's also a subclass here, depending on the tips of the papilla. So basically, in brief, the more severe the classification here, the more worse is your soft tissue defect. You have facial deficiencies, you have loss of papillae. So based on this classification system, which uses the soft tissue margin and compares to the location of the adjacent homologous natural tooth, so it's a worse progression from 1 and 4. So they recommend doing a coronally advanced flap or a tunnel or a combined approach in type 1 situations, whereas in type 2, no crown removal yet. Okay, in type 2, no crown removal, coronally advanced flap, CTG, maybe you want to remove the crown and maybe put a provisional along with soft tissue grafting. Now, you see, when we start getting into type 3, class 3 and class 4, these are those severe kind of defects. I'll show you some of our cases where you have to remove the prosthetics and then give the patient maybe an Essex appliance or a partial appliance, something, because we cannot do these surgeries when the crown is still there. And then you approach with the connective tissue graft, or you submerge the implant and do a grafting kind of situation. And in type 4, class 4, you again have to either remove the implant and do a combined approach. Okay, so this is a good classification system to make to see where your patient falls once the implant has been restored. So this is one of our cases done by a former resident, Dr. Diaz, and then this was corrected by our current resident. So you can see this is like a, looks really worse, right? But when we place the implants, not bad, right? We all probably can agree that this doesn't look bad at all. But what's the problem here? So again, 2 adjacent implants, we know it's never a favorable outcome, even though they are more than 3 millimeters away from each other. It's pretty flat profile, right? There is no crestal bone here that can retain the papillae. And then this is a grafted site. So even though the implant was successful, our aesthetics are really bad. So the patient here, the patient really didn't care. The prosthodontist was the one who referred the case back to us. I mean, this patient also had other issues, erosions and things like that, which are managed. So what did we do to this patient? So this was probably your Zucchelli class 3 or maybe even a class 4. I would probably put it in a class 3 deficiency. So we told the patient we have to remove the crowns. We put the patient back on S6 appliance. We opened the flap. The implants look relatively nice. There's still enough bone, but look at the platform level. Look at the CEG of the adjacent teeth, pretty deeply submerged, right? So that's the main problem. We just don't have enough bone here, and ideally, this peak of the bone should be much higher for us to keep the papillae over there. So in this case, we did what they recommended here. We took a thick connective tissue graft, and then we put like an onlay graft here on the occlusal aspect and also on the facial aspect. And then we really stabilized this graft really well. And then we let it heal. And this is how the patient healed. So now you see, compared to the pre-op, this has really, we augmented mostly the soft tissue aspect. So now this patient was restored. And I wouldn't say this is excellent outcome, but compared to what we had from pre-op, this is relatively a reasonable situation. But again, we should never have ended up in this situation. This should have been addressed even before the implant had been placed, or maybe an alternative prosthetic option could have been chosen in this patient instead of an implant. Remember, implants are always not the only option. There are other options that might be more aesthetically pleasing outcomes for our patients. So with that, I will just give you my take-home summary. I know I probably went over my time, Dr. Vikender. I know I covered a lot in this hour and a half. So the need for keratinized gingiva teeth is typically a need based on what your patient and your clinical judgment, and it also depends on your patient compliance, right? Not all patients will need a root coverage, and current evidence does suggest the benefits of adequate keratinized mucosa around implants for functionality and prevent recession and marginal bone loss. Free gingival graft is still the gold standard for gaining keratinized mucosa. I would say for both around teeth and also implants. And connective tissue graft, regardless of the technique that you are going to use, is still the gold standard for root coverage. And soft tissue and hard tissue augmentation prior to implant restoration is really beneficial for optimal aesthetic outcomes. And connective tissue graft, again, seems to be ideal choice for soft tissue augmentation around implants. So again, somebody like me who was classically trained in Perio long time ago, so it's basically the same techniques that are coming back, like how now we are trying to save teeth, and not do implants. Same thing in soft tissue grafts also. Still FGG and CTG are still the gold standard. Of course, we have other alternatives that might apply to your patient situation, but old is still gold, folks. Okay. So this is just my team. This is our department. At a recent meeting in Southwest Regional Perio, where we have 10 universities competing, all the residents are presenting, and these are on the right side. This is my department chair, Dr. Angelo, and these are my 4 graduating third-year residents. So I use some of their cases, and I would like to acknowledge their contribution. And here we have some faculty members and other members of the department, the junior residents. So yeah, thank you again for this opportunity, and I hope you have something to take away today from this presentation.
Thank you, Dr. Srinivas.
Oh, thank you. It's good to see that there are still 95 people out of 100. So, so people didn't leave. That's good.
It was a wonderful presentation from your side, and you left no stone unturned. I found you covering from the basics till the latest, and overall justifying the term current concepts in perioplastics. And I think there are a few questions in the chat box, and Dr. Vikender Singh will address the chat box, and
yes,
he'll be moderating the session.
Okay, thank you. So I apologize if I was talking fast. I was trying to cover. I know I'm respectful of your all time. I know it's your morning time. It's your clinic hours. For me, I can go on. It's only midnight here. It's 1 o'clock. Thank you so much again for the feedback, Dr. Gautami. Dr. Vikender, I'm ready whenever you are.
Yeah, thank you, Dr. Srinivas, for the captivating presentation and about soft tissue grafting around teeth and implants, which you presented by showing several clinical cases. And I hope the audience which joined us through this online platform must have been benefited from your lecture. And I would also like to congratulate Dr. Gautami and appreciate her efforts for regularly conducting such programs for the aim of spreading knowledge among the periodontists across the country. Before we jump into the questions related to your presentation, I would like to know how do you see the perspective and practice of these procedures in among the clinicians in university settings and clinical settings in the two countries, because you have worked both in India and now you are working in US. So how do you see the perception of the clinicians about these procedures in two countries?
It's a good point. I think, let's see. I did. Yeah, that's a good question. So I see. For example, right now in the practice where I am, I don't get much soft tissue. I'm doing mostly implants and perio, like GTRs, flap surgeries. So very little soft tissue cases. Whereas in the university, because the residents want to learn, they will convince any patient to do soft tissue grafting, even though theoretically, based on evidence, they really do not need. So I'm sure even your PGs will be pushing you, right? Let's do this technique, sir. Let's do this technique. So I think in university, I think this is primarily driven by the PGs, I would say. They're trying to convince patients. But again, I only practiced in India maybe for 2 years after I graduated. So I really, I did mostly, I would say, periodontal procedures, not too much of soft tissue grafting. But in the United States, I know Dr. Gautami told me perioplastics is a big thing. And I know, Dr. Vikender, you do a lot of research on that, and you're an expert in that soft tissue area yourself. I think periodontal plastic surgery is a big thing in the United States private practice. It's a very popular technique, and periodontists feel that this is one technique where the periodontist can do better service to the patients. Because nowadays everybody is placing implants, right? Everybody, does extractions, maybe flap surgeries, but I think soft tissue grafts is still somebody refers to a periodontist. So I think the soft tissue procedures are really popular in the United States. I would tell you, especially in the university settings, the residents, the PGs at least, I will tell you, at least in our program, they will do a lot of these full arch soft tissue grafts, but we do encourage them to kind of understand the rationale. Patient selection, patient education is really important. But I would say after implants, the soft tissue grafts are really more popular in the United States. So I don't know. I mean, you tell me about the Indian situation. How are our Indian patients? Are they receptive to get these surgeries done? Because when I was in India, really, they did not even want to save the tooth. They would say, don't do a flap surgery, just extract the tooth. I'm okay with that. But I think now India is an economic powerhouse. People are more aware, more educated. So I'm sure things have changed for the better now.
Yeah, definitely, Dr. Srinivas, things have changed a lot now. And the other day, Dr. Gautami was telling me that the days she opened the registrations for this program, all the seats, actually it surpassed the numbers the Zoom, in the Zoom meeting she could have. So 100 registrations she got in one day only. So it shows that how keen the clinicians and the students and the faculties, they are interested in learning and doing all these procedures. Regarding the question that how receptive patients are about these procedures in clinical practice, my take on this is that first we ourselves should be confident enough to convince the patient to tell them that how this procedure will help them for a long-lasting treatment, whatever we are offering to our patients, and only then these can be practiced.
Thank you.
So now, coming to the questions from the participants. So one question is, what is your experience about the efficacy of mucograft in encouraging keratinized gingiva? Do you really find it efficacious in KT gain compared to FGG? Although the studies, I know they say that the results are comparable, but in clinical settings, What is your experience?
Yeah, I'll be honest here. I showed you a case that worked. I did not show you cases which did not work. That's what, so, I would say 50-50. I think in our experience, we have done few cases. In some patients, it worked. In some patients, it did not really work. Because, I think the case I showed you, the patient had good vestibule. He already had some KT. So, and then we were able to stabilize the mucograft. Then I think it works. But in situations when you have implants or like teeth with very low vestibule, very shallow vestibule, and you have no adjacent keratinized tissue, we did not see mucograft successful. But the reason we tried was patient did not want graft to be taken from their own palate. But I would tell you, free gingival graft works anytime. As long as you stabilize it really well with good suturing and good recipient site. But mucograft, I would say the success rate, at least in our program, is about 50%. I know Mariano Sands and others, Schmidt, have shown very high success rate. They're also master clinicians, right? So they have a lot of experience, and that's what they do day in and day out. And the patient selection is very critical. Our patients, as you mentioned, are completely different. So I think you have to, I think in a good case selection, where you have already some 1 to 2 millimeters of thickness in good vestibule, I think it could work. It could be a good alternative. But also remember, the material is also expensive. It adds on to your cost. Whereas free gingival, there's no free. It's free. You just go to the patient's palate and take it out, right? So that is I would say that is my opinion. But again, I'll be honest. I have very limited experience with mucografts, very few cases. So maybe we need to do more cases to kind of see where we are.
Yeah, exactly.
I do
you
have a lot
said,
of experience with. Sorry, go ahead.
Yeah, that's what you were saying, that there should be at least 1 millimeter of keratinized tissue to place or stabilize the mucograft. But clinicians, they usually want to use it where there is lack of keratinized tissue. And they are anticipating that it will result in some form of keratinized tissue, particularly when they are using it around implants. So I share the similar experience that the results of mucograft are, if not uh, equal, but they are almost, we can say, equal to the vestibuloplasty procedures. So you get that scar line in the vestibule, and there hardly any keratinized tissue is visible.
Yes. Yes.
And with time, after 1 month or 2 months, or down the line 6 months, we don't find any keratinized tissue, which we can say it is superior to the even vestibuloplasty procedure alone, and considering the cost of the product also. So
I agree. And we also don't know long-term, Dr. Vikender, how stable is the keratinized tissue that we get from mucograft, right? You might
Yes.
lose that keratinization because the origin site is not really from humans, right? It's an animal-derived product. So we don't know the induction, the genetic mechanisms. So I think more research needs to be done. But again, in some patients, as I mentioned, if you cannot do FGG, patient has some other medical situations, bleeding issues, it could be a viable option, though it may not be the best outcome. But sometimes you may not need 100%, maybe even 80% of good outcome is very good for the patient, So
actually, case selection is very important if we have
yes,
to use such expensive materials. So one
100%,
question
I
was
agree.
from Dr. Ashok. He was asking about how is mucograft comparable to FGG in terms of tissue compatibility.
In terms of aesthetics, like the color match, I think the color
Probably you
match,
want to.
the compatibility, I think mucograft is definitely better. Remember when we do FGG, it's very highly keratinized tissue, especially, we don't like to do FGGs in the maxillary anterior because of the aesthetic concerns, right? But typically, FGGs will leave a more whitish tire patch like appearance that's listed in the literature. Whereas mucograft, I think even if you look at the studies and based on what our experience in our clinics is that the color match is much better. It's definitely aesthetically compatible. Now, I don't know what the question is about, functional compatibility or aesthetic compatibility. Aesthetically, it's definitely compatible, for sure.
Yes. Yes. There is one more question, but I think it is related to hard tissue grafting. Autologous graft versus bios. What should be the choice in ridge defects?
Sorry, can you repeat the question?
Uh,
I was responding to one of the messages,
that's
Dr. Ashok KP. He was my classmate in BDS.
okay. Okay. So this is question something related to hard tissue augmentation, not soft tissue. And his student he asking about autogenous graft versus bio-os. What should be the choice in ridge defects?
Well, so I think that's a good question, right? So we use BioOS. So I think if you look at studies from San Antonio group, Wood and Mealy, so they have done a lot of good case studies comparing, I think from a long time, Dr. Brian Mealy um, from San Antonio, University of Texas. So they are our neighbors, like 3 hours away. So they compared DFDBA, FDBA versus BioOS. So typically, it depends, doctor, what your outcome you're looking for, right? So in Europe, actually, they cannot use allograft because human grafts are not allowed there. So they only use xenograft like BioOS there, and they have shown actually good results. The only difference is you have to wait little longer. If you do rich preservation with BioOS, studies have shown that maybe at there is 37% of residual graft still left at 7 or 8 months. Whereas for allografts, the turnover, there is more vital bone very quickly. As early as 4 months for DFDBA uh, and also FDBA. So if you care about vital bone, more native bone turnover that you want your implant to contact with, I would say go with allograft. But if you if you want something to stay longer, like for example, you're doing a severe ridge defect where you have lost the buccal wall completely, and you want something that will stay long term and prevent quick remodeling, I would suggest use BioOS. But one caution is you have to wait a little bit longer. I would suggest you to wait 7 to 8 months. But studies have shown, a lot of studies, Ronald Jung has published papers that showed that no matter what graft you use in your ridges, implant are always successful. But we still don't know. The interesting part is what kind of bone to implant contact are we establishing when you have native bone, when you have the turnover bone with allograft versus the residual graft particle. So we need to look at those studies even more. But great question. So it depends. So some of the patients are probably religious too, right? Some of our patients in the US, they will say, don't put any human graft in my mouth, no animal bone. So what do? We use synthetic graft. We use tricalcium phosphate, you know. And actually studies have even shown, Dr. Nevins and others have done some studies on tricalcium phosphate with a synthetic hydroxyapatite. Even that works, But some people just like, oh, I want to use allograft, I want to use xenograft. But I think each has a role, I think, case selection and what kind of graft you're using. But yeah, a xenograft can 100% be used. But I would just suggest wait a little bit longer. Otherwise, when you go back to open the flap, you will see some particles still when you're drilling, or there is usually some soft tissue encapsulation of these particles. So typically in our program, we tend to use xenograft in large ridge augmentations and sinus grafts.
Right.
Lateral window. A great question. Thank you.
And one last question from the messages is that should we augment, if possible, even 1 millimeter of attached gingiva? If there is only 1 mm of attached gingiva, do we need to augment it, or we can leave it like that only?
That's a good question again. So again, I will look at how much recession your patient has. Does the patient have any sensitivity? Is there bleeding on probing? If none of these factors are present, bring the patient back maybe in 6 months and reevaluate. If there is progression of recession, I showed the study, one of the study by Shambroni and Tatakis. So they showed that untreated facial recessions, there is progression. But we all know in periodontitis, in the periodontal disease, the progression is very slow. Perio never rapidly progresses. So I will reevaluate your patient to see if there is progression of recession, if the patient has any sensitivity. Again, if the patient is going to go for any orthodontic therapy. So a lot of factors that he might benefit from augmenting, because we know that in some situations, if the patient has crowns, maybe the tooth is a abutment for a fixed partial denture or an RPD, it might benefit from having a little bit more keratinized tissue. So in those cases, yeah, I would definitely recommend to my patient augmentation. But again, remember, if your patient has 1 millimeter of attached gingiva, that means he has at least 2 millimeters of keratinized mucosa, right? Because you also have the sulcus part. So the 2 millimeters should be probably more than be adequate.
Yes, exactly.
Great question.
So,
thank you.
And there are no other questions. There is one question from my side only. So, do you use any method of root surface biomodification in your root coverage procedures?
Yeah, no, excellent question, Dr. Vikendra. I know I forgot to mention that. I apologize for that. I know I skipped through the cases. Yeah, I mean, typically, the current consensus is that when we are doing even root coverage, we just scale and root plane and remove the smear layer. I know classic studies for periodontitis, they used to recommend root biomodification with EDTA and phosphoric acid, tetracycline, But right now, I think there is no current recommendation. I don't see the value. The only time we do root conditioning is when we do endogain, enamel matrix derivative, because the manufacturer recommends using that phosphoric acid. So I think the goal of doing root conditioning when you're using enamel matrix derivative for doing root coverage, Dr. Scullion has published a lot of papers on that. I did not cover that in specifically, is to remove the smear layer and then create some microporosities in the cementum, so your growth factor can actually go and reside in those small microabrasions. So that's only with the enamel matrix protein protocol we do root conditioning. Otherwise, what we all do is just clean the root, any free calculus and plaque, and then we rinse it out with saline or normal sterile water. Yeah, we are not doing any additional root conditioning. That's a great question. Only when we're doing enamel matrix proteins.
Yeah, but again, cost is an issue and availability is another issue here in India. About the
I mean,
enamel matrix.
fortunately, oh really? Yeah, fortunately it's available here. We do a lot of cases, but we are using it more for GTR, for regenerating intrabony defects, than root coverage, because it's also expensive here. It's probably a small, I think it costs about $400 or something. So we have to add that to the patient's surgical code. So sometimes patients may not approve, even the US patients. So we end up doing connective tissue graft because it's probably more economically beneficial for them. But again, studies have shown that coronally advanced flap with enamel matrix proteins has pretty good success rates compared to connective tissue graft. But yeah, again, if you're doing coronary advanced flap by alone itself, CTG, we usually don't do connective tissue root conditioning routinely. I don't think there is any conclusive evidence at this point for that. But great question.
Thank you, Dr. Srinivas. You patiently answered all the questions, and thanks once again for the excellent presentation. Over to you, Dr.
Well, thank you
Goswami.
so much.
Hello, Srinivas.
Hey, Dr. Bagele,
Hello.
how are you?
Yeah, very nice presentation.
Oh, thank you so much.
Very good cases. Excellent.
Thank you. How are you? Thanks for attending.
I'm not going to ask you any questions.
No, please feel free. Dr. Bagele and I did the residency together in GDC Mumbai. So, he's a professor and he practices in Thane. So probably I'm sure everybody knows him.
Really nice. We have done SBET at that time during 2001, 2002 on connective tissue grafts.
Right. Lateral pedicle graft, yeah.
Yeah.
At AIMS New Delhi and Petro. Any more questions from the audience? Yeah, I think your presentation was very crystal clear and it was very explanative, Dr. Srinivas. It was a wonderful presentation. And as I see, as even Dr. Vikender was telling, that perioplastics are the recents in periodontics now. Like most of us here, even the postgraduates, are inclining towards perioplastics and implants rather than the regular periodontal conventional flap surgeries. And so not only in the US, even in India, we have taken a huge leap, especially I think in the last 4 or 5 years. Many people are joining Perio to learn perioplastics, and which will be again helpful around perio implants also, perioplastic implant, peri-implant procedures, because implants are being placed more by a periodontist rather than anyone else, because of our accommodation with the soft tissue and our knowledge and our sensitivity handling towards the soft tissue. And likewise, I would like to tell here that since the year 2018, till then there were no workshops or no separate training for perioplastics. But especially once this AIMS New Delhi has taken up it as a unique initiative since the year 2018-19, slowly people are joining in, and the quest to learn perioplastics has become more in the Indian scenario. And likewise, AIMS, I think, recently has conducted a workshop just 10 days back in AIMS New Delhi. And the upcoming workshop is also coming up in the month of September under the guidance and under the mentorship of Dr. Vikender and Dr. Sharvanan. And this is the brief share of the program. I think all of you can see. And surprisingly, 1st April was the registration day wherein the registrations have opened. And by 1 o'clock in the afternoon, the registrations for all the workshops were over, like starting from 5,000 till 20,000, like on cadavers, on sheep mandible, everything was over a period in a matter of just in a span of few hours. And the same way, even when your program was put up, by evening, we had an overwhelming response and almost 98 registrations were over on the single day. And this shows how the interest in perioplastics is arousing, and it's really taking to Perio to great heights. And this is the coming up AIMS workshop at Delhi. Next.
No, very nice, very nice, Dr. Gautami. I also tell the PGs and the residents that Perio is never going to be out of fashion, I would say. All those implant complications, guess where they will go? They'll go to periodontists, right? We are the ones fixing those hard tissue complications and soft tissue complications. So there's always will be endless supply of patients to fix those. Again, I think we should be saving more teeth. That's the opinion. I think in the US, at least they're going now. So again, I think soft tissue regeneration is what something periodontists can do. And it's a great benefit for our future graduates, I think. But congratulations on your AIMS program. I think you guys are doing fantastic.
Thank you.
I think definitely
Sayan Baruchi is coming.
Use of it.
Oh, Baruchi, okay. Yeah, Michigan group.
Yeah.
Yeah, so, yeah, they're all from the Michigan group, right?
Yes.
Taveli, Baruchi, they all train with Home Levang and good people.
And that was a fantastic show, Dr. Srinivas, along with Dr. Vikender and all the participants who made again the 5th edition of Perio Akshaya very successful and very enthusiastic for all of us here. And in this regards, we would like to profusely thank Dr. Srinivas Ailavarupu for being there at the odd time. I think it's almost 12 o'clock in Houston.
1:15 a.m.
Okay.
It's fine.
1:15. It's almost midnight, and still Dr. Srinivas is as fresh and as enthusiastic as all of us are here in India. And thank you, Dr. Srinivas. And here is a certificate of appreciation from Vishnu Dental College for your wonderful session on the current concepts in perioplastics in this 5th edition.
Thank you so much.
And eagerly waiting to see you in India soon and visit.
Thank you. Thank you again. Yeah. Have a nice day, everyone. And thanks for having me.
Thank you so much. And Dr. Vikender, your efforts are never, they don't go unappreciated. And thank you so much for being a part of this in spite of your busy schedule and taking special permissions from AIMS and making yourself possible and visible in this 5th edition of Perio Akshaya. Thank you, Dr. Vikender.
Thank you, for inviting.
And wish you all the very best for your upcoming program on perioplastics. And we wish all of us attend personally and take the best out of it. Thank you so much.
Thank you.
And thank you, Dr. Baljit,
sir,
for moderating the session, again, in spite of your very busy schedule. And thank you so much for always supporting us in all our endeavors coming from Team Perio at Vishnu Dental College. Thank you once again. And thank you, Anand sir, for being there throughout the program. And I think, I know you do most of these procedures, but you remain very silent at the end of the day. And Dr. Anand sir's publication one is there in IJPRD, wherein it's a soft tissue augmentation around an implant with a 10-year case report. And it's done by an orthodontist as efficaciously as a periodontist does. And so thank you, sir. And your encroachment into Perio is always welcome. And you can always guide us, like as you guide other departments too. Thank you so much.
Thank you, Gautami. Thank you all for attending the program. And Srinivas, it was an excellent program. And I'm sure there's a lot to learn. And Vikender and Dr. Baljit, both of you, thanks a lot for moderating the whole session. Thank you once again.
And thank you all participants. And please fill in the feedback session, which will be mailed to your email IDs, and wherein the certificate for the 5th edition of Perio Akshaya will be automatically generated. And thank you once again for all your support. And special thanks to Arun sir and Dr. Srikanth for being there throughout the presentation. Thank you once again.